Okay. We talked a little bit about the knowledge-due gap. One of the important things we all talked about this morning is cost and outcomes and stuff like that. One of the main reasons because of that is variability of the care. We constantly talk about it because we need to standardize care because most of the physicians, we all think that medicine is an art rather than a science. So most of the physicians, including me, keep talking about, okay, every patient is unique. You cannot, make medicine like a, cookbook. But that's not really true because 80% of the patients actually can benefit out of standardized care. So when I was a CMIO on a large healthcare system, we have the advantage, the luxury of 44 hospitals feeding the data into a clinical database. So we came up with standardization of care for common conditions, and then we collected the data on outcomes and also cost. And we were able to show that if there's a standard care practice, we'll be able to save money by 20% and increase the outcome in terms of patient satisfaction, length of stay, and things like that. The reason being, like if we talked about antibiotics, right? So what we found out that if you give them a lot more choices, that kind of increase in variability, right? And then if the choices are limited, we actually found that even though we gave a lot of choices for clinicians, they always pick the first antibiotic in the list. So 95% of the time, we saw that the rest of the antibiotics is not used. So then we analyzed it because it makes it easier for the nursing and other support staff if the variability is not there, because they know exactly, okay, the doctors are going to order this. This is how I need to take care of the patient. So it makes it much more easier and much more efficient. So the outcome is reflected in that. So it's one of the important things is standardization of care. But we also talked about every physician they bring their own, how they are trained. So there's a lot of variability. But what is important is, how to bridge the gap between what is evidence-based today, what I know, what I've been trained, and what is evidence-based today, and we need to kind of bridge the gap. And we talked about, making up-to-date available. Yes, that is one step, right? So I need to know what is latest and the greatest, but also I need to be prompted at the point of care what I need to do, because I may learn all that, and then I may not practice the same thing when I'm in front of a patient. So it is important that point-of-care decision support is extremely important because that is the time also is the best time to educate the patient. If I have a problem in front of me, if the system tells me that this is the way to treat the patients, I treat the patient. The next time when a patient shows up in a similar way, I know I've already done it. So it's a practice that makes it more, perfect. So, the Dr. Lee Jong told about, the knowledge-due gap. So we need to fill that gap, and you hear some of those things when I talk about it because that is exactly what we want to do, how to bridge the gap. And that is key to reducing the variability of the care. So I'll talk more about it on that. Okay. This is a room full of doctors, so I'm not going to ask what is it. So this is actually a strip from Up to Date. And when we talk about variability of the care, as you can see, I haven't looked at the EKG for some time now. I can definitely say that the QRS complex is not regular because the space is altered, and I don't see a clear P wave. So it's a case of I think there's two cardiologists in the room. So this is an atrial fibrillation, and one of the things that we found out is that more than 30% of the patients are not getting the appropriate therapy for atrial fibrillation, even though there are, evidence how to treat them. Most of the patients, 70% of the patients will actually benefit if you put them on a blood thinner, anticoagulant. And also, once you decide to put the patient on an anticoagulant, you've got to find out what is the best anticoagulant to use, and also how to monitor them in terms of how much to use, how to adjust the dosage, and things like that. And believe it or not, a lot of patients are on aspirin. Patients on atrial fib. So that's a huge problem. So changing physician behavior is really a hard one. So that is actually a science that we have to find the right opportunity to educate them and the way they can comprehend that, and the way it is aligned with their workflow. So, okay, we again talked about unwarranted care, and I want to give you an example. So the variability of the care is just phenomenal. So there's plenty of studies that have come out about that. So it's kind of interesting because two sets of population, exactly matched demographic population, the way they are treated, even though they have the same problem, depends upon where they are. I mean, it's mind-boggling to figure out how can that affect, because the way you're going to treat me depends upon what I have and what I need, not where I live. So this study, as you can see that, they studied the New Haven, Connecticut, and Boston, and they found out that even though they matched the same demographics between these two populations, so you are likely to get coronary bypass surgery twice if you are in New Haven, Connecticut, than in Boston. And also, if you are in Boston, and we talked a little bit about C-section, right? So this is another thing. Then you're more likely to get a hysterectomy surgery in Boston, actually about 50% more in Boston than if you are in New Haven, Connecticut. So, and then on the contrary, if you happen to be in Boston, you get carotid artery surgery twice compared to New Haven, Connecticut. This is just a simple example, and we have done quite a bit of work, even in Orlando, two hospitals which are only 10 miles apart. There's a huge variations in how patients are treated. So that is a huge problem. That is one of the key reason for healthcare costs, skyrocketing healthcare costs because of the variability. Okay, this is some statistics on where healthcare is going. And as you know, United States, right now it is about 17% of the GDP is the healthcare cost. So in 2015, the total healthcare cost in the US market was like $3.2 trillion. It's just atrocious. And then the way in the healthcare cost is growing is about 1.3% more than the GDP growth. So if you continue on that trajectory, it's self-sustaining, right? So this is very, very important. We are in this juncture that we need to do something to control the cost. About 30% or 35% of the cost is because of wastage. So if you can contain that, that itself will reduce the healthcare spending phenomenally. So, we really need to look at that. And of course, the population, right? The life expectancy has grown over the past years. And US, 60-plus population is expanding. So that is a huge burden on the healthcare system. Because those patients use about 80% of the healthcare resources. So we need to really do something about it. And of course, again, we keep talking about high variability of the care. It's just, if a 747 crashes, I always talk to doctors about it, to get a sense of how serious is the healthcare, the patient die of adverse drug events. So, if a 747 crashes, that is going to be the news for days and days to come, right? And imagine more patients die every day because of this, and nobody's talking about it, and the public is not aware of that. So we need to definitely do something about it. There is incentives for reducing the readmission rate, and one of the important things why patient gets readmitted is we are not following the patients after they are discharged, because that is where the important events occur after you get discharged. They need to be followed up to prevent readmission. So this, again, is because of the physicians are not following the greatest and the latest, the evidence-based care. It's because they treat based on what they are trained, which is no longer valid. And then they are not keeping up to date with what is the current treatment, techniques. So we hear all the time, you treat unnecessarily certain things. If you can do it conservatively, you don't do it. It's like, prostate cancer is a classic example. There's a lot of studies that are done that what is the way to treat prostate cancer. I'm a 60-year-old with no symptoms. If the PSA is high, then people are getting operated on the prostate cancer. But, wait and watch policy is another way to treat the patients. Depending upon where you are, you may get a prostate surgery or you may be treated conservatively. So even though it's the same patient. So that is not right. And then, the patients are not educated on what are all the options. If you take, for example, prostate surgery, they need to be educated of what is the pluses and the negatives of a surgery, like incontinence and going through complications and all that, and what is the advantage of doing it conservatively. So we need to kind of empower the patient, have the discussion with the doctor to choose their, what they're comfortable with, which is what we talk about value-based care. What is the value for the patient? So that's extremely important. And hospital bills include unwarranted items, unnecessarily, using, things that are not necessary. I want to give you an example. We did a study on one of our hospitals in Chicago. So what happened is orthopedic surgeons are highly paid, and they think that they bring a lot of revenue to the hospital. Okay, they are very proud about what they do, and I agree that they do a lot of hip replacement, knee replacement. So we did an analysis because, again, we talked about digital health and the power of the data, right? You can literally track what they are doing, how the outcome is. So we did a study, and we found out that the hospital is losing money on these orthopedic surgeons. And, you don't talk to an orthopedic surgeon that what you're doing is not right, right? So what we did was we collected all the data and called all the orthopedic surgeons and had a discussion. See, you're doing this many surgeries, and this is our cost, and this is what we are claiming from the reimbursement. And as you can see, it's negative. They were literally shocked to see that graph because we were able to show them the data. It's not that what we think they are doing, but we are actually able to demonstrate that they are losing money. So, and then they said, how come? They were literally shocked because they thought they saved the hospital. And then we went through deeper into it and found and actually showed them why they are more expensive, because they are ordering a bone cement which has impregnated with the antibiotics, which costs 10 times than if you can buy a generic cement and our pharmacy can actually mix the antibiotics that they want. It costs 1/10. And they are not ambulating the patient. They're not educating the patient for ambulation. So just do the surgery and that's about it. So we found out 3 or 4 different factors that can contribute in reducing the cost and making the patient experience much better. And they said they want to be the doctors who can bring in the revenue. They said, tell us what to do, because their ego is hurt, right? So they said, okay, these are all the 3 things that we are going to do. And they followed it like, to the core. And then we were able to break even. So from the negative, we were able to come positive within like 3 to 4 months. So the reason why I'm telling this story is that data is our power. So it has to be transparent. And one of the things that doctors really don't, they're very competitive with their peers. So they want to be the best. So transparency is extremely important to compare treatment and discuss the outcomes and things like that. So digital health records definitely help us in doing that. In the paper world, there is no way we can track that. And then lab test, because we actually use what is called a shotgun approach. So when a patient comes, we order all the tests without realizing what value it brings, rather than picking and choosing the right test based on the specificity and sensitivity. So that if it's a screening, you've got to choose one test. Where it's a diagnostic, you've got to choose one test so that we can understand the value of those tests. So that's another thing, that 20 to 40% lab tests are ordered without a clinical basis. So we know where the waste is, right? So if we can incorporate some of the clinical decision support that can help the patients reduce the cost and the high value dollar, then it's a no-brainer. We talked about variations of the care, and it's often we wonder why there is so much of variations in the care. And one thing is, of course, I talked about it, we are all trained differently. And the way we are taught by our attending when we are a resident, we continue to practice that. And depending upon our call, once we become an attending, then we discuss our case with our co-attending physicians, and we practice. So, and we are so busy, so many patients, our workload has been increasing, there is no time, the literature is like pounding us, it's impossible to keep up to date on the literature. So that's one of the main reasons why there's the variations in the care. And the variations in the patient preferences, I already talked about the example of prostate cancer. So, a well-educated patient is a good patient. In this day of technology, Google, we talked about Google, right? They go back all over the internet and collect information, and most of them are not authentic information. They bring it back. So it's extremely important that we need to educate the patient on the right thing and then involve them in their clinical decisions. So that is one way we can reduce variations and reduce cost. And then, of course, the third one is variations in supply-sensitive care, which is another problem, right? So if there is a hospital with urologist, for example, they started a new service with urology, then guess what if a patient with prostate cancer comes? They're going to get a prostate surgery, right? Not conservative treatment. So availability of specialist care in a particular hospital will kind of divert some of the decisions towards that because it's a profit center, so they need to generate profit. So it is not to the best interest of the patient, but that is another reason for variability of care. Okay, so this is a report that came out of the advisory board. So you probably are familiar with the advisory board. It's a large analytic company in the US. And they talked about variability of the care. And you can only do so much in terms of streamlining the process and then improving the procurement and all that. But a major chunk of the variability is because of what we have been talking about, variability in the care. And it's very difficult to influence the doctors to change behavior, right? So, when advisory board went and talked about it to the CEO of the hospitals, they all said that what keeps them awake at night is how to change physician behavior, how to make them follow a standardized care for various things. So that's a huge problem. We talked about IHI and their triple aim framework. It's actually a great framework if you think about it. It's a lower through improvement, right? Better care for individuals, and if you care for the individuals, it is going to improve the healthcare of the population, right? Great framework. So how can you practice that? How can you translate that into actual solutions? How can you take that as an example, as a framework, and then provide actual solutions that we can implement and make an impact? I've been involved in the CPO implementation. There was a lot of government incentives that was provided, millions of dollars if you put EMR in a hospital. At that time, people all thought that EMR is going to do the magic. If you put an electronic medical record in a hospital, the care is going to improve and life is going to be good. But what happened is it didn't make any difference. In fact, it actually made worse because physicians were frustrated, they were complaining, and so it didn't make any difference in the EHR, right? Because one of the things then when we implemented EMR, what we did was, we failed, right? And we came back to the drawing board. So one of the key success in any implementation is physician behavior. We always call that EMR implementation is 95% change management, 5% IT. Because most of the hospitals think that it's an IT project. EMR implementation is an IT, but no, it is behavioral change. So when I talk to the physicians, I tell them this joke because nobody wants change, right? Nobody wants change. They always want to stay on the comfort zone. The only person who will like change, do you know what? Is a baby with a wet diaper. They're very uncomfortable. They need a change. Other than that, nobody would like a change because they always want to stay on the safety zone. And then once the EHR is in place, EHR is really important because we talked about data, digital data. We were able to do analytics and stuff like that. So that's a platform we really need that to capture data and build that database. And then we put CDS, clinical decision support, on the top of the EHR. And even then, there are small quality gains. And we talked about alert fatigue. And what is the point in clinical decision support? 80% of the doctors are not even looking at it. That's a problem, right? Because to a certain extent, I agree, 80% of the time, 40% of the time, the alerts are not meaningful because it is not taking into patient context. a lot. So some of the things that we are doing is how can we incorporate more patient context before alerting so that alert becomes more meaningful. So because we have kind of lost the trust of the physicians in clinical decision support because most of the time it's not telling them what it's supposed to do. So we need to earn that trust back. The only way to do that is make those decision support more meaningful clinically. So CDS actually made only very small gains. And okay, so John Weinberg is a physician in 1970, talked about variations in the care. 1970, he wrote a review article on how healthcare is management is variable. And he wrote a follow-up editorial in 2015 that is about 45 years later, and he's saying nothing has changed in 45 years and still counting. So nothing has changed in 45 years in variability of care. And when we talk about it, what is different now, right? So, do you think it's going to change for the next 40 years? But I think we are pretty optimistic of the following reasons. One of the things is we talked again and again a cost-quality equation. The cost of healthcare compared to GDP, it is self-sustaining. We've got to do something, otherwise the whole thing is going to crumble. And so that is the driver to think about it. You're thinking about it, we are going to move from care for service to evidence-based care, care for performance. So definitely that is an impetus for change. And then limited liability to measure outcomes and impact of care. And I gave you an example of this orthopedic surgeons in a Chicago hospital. The best way to do that is able to measure how we are practicing medicine and translate that into outcome, and then link that, saying that, okay, if you do X, Y, and Z, we can clearly show improvement in the patient outcome. So that is extremely important. And that is being, digitization of healthcare actually helps with analytical tools. Computer is getting more and more powerful. So it is able to crunch a lot more data, and there are a lot of machine learning techniques. The machine can actually look at the patterns and give us some ideas about, how. So these are all the tools that are available. So once we have a digitized healthcare record, that is kind of a gold mine for us to work on. So that is changed. And the EHR inflexibility, and to a certain extent, it still happens, right? So if I have a Cerner system, it won't talk to the Epic system, right? Even Cerner hospitals, one Cerner hospital can't talk to another Cerner hospital because their implementations are different. So a lot of work has done on standards, like HL7 standards is a starting point, and there are a lot more standards that have evolved, but ICD-9, ICD-10, line code for lab test. So there are some things that helps us to integrate between different EMRs, because that's extremely important to contain cost, because if I go to one hospital, they do a bunch of tests for me, and then I go next month to another hospital, again, I had to go through all the tests because data is not accessible to other hospital. So that's a huge problem with the cost. And about Smart on Fire, which is a new standard that is evolving. And it has got a lot of promise that if we build a CDS system for Cerner, it's supposed to work with Epic, because there's a lot of push from the government as well on Smart on Fire. You may want to look at it because it's more like iPhone, right? So people who have iPhone, what happened? iPhone doesn't, make all those apps. So it is open so that any vendor can make apps that is compatible with iPhone. So that resulted in multitude of apps that are available that you can pick and choose. So that is the vision of the Smart on Fire, because they are thinking that, cardiology, a company can build an application that is specific for cardiology, so you will be able to integrate that with an EMR. Then you'll be able to do specific things on that. So that is. So we need to wait and see how exactly that is going to evolve. So, and the EMR are also beginning to talk to each other and trying to figure out how they can help. So I think, again, the consumer, as physicians, we have to push them. That's the only way it's going to happen, because unless the consumers push them, we won't move forward with that. So I think that's a good thing. And then we talked again about patient-centered care, right? Healthcare has always been physician-centered care. Physician is the center of everything. He decides what is good for the patient. That is changing with the patient-centered care. The patients are getting more knowledgeable. They have access to internet. They can get a lot of information from their friends. And they are starting to have the discussion with the doctor. So one of the things that I heard, because we are working on pharmacogenomics, personalized medicine you have been talking about, drug companies, things that one shoe size fits all, because it's easy for them to say that. Plavix, for adult over 18 years, this is the dosage. But that doesn't work that way because everybody is different. Everybody processes the drugs differently. So pharmacogenomics is something that is coming, and then there are a lot of companies like 23andMe, which is marketing directly to the patient. And the patients are going to the doctors and saying about, what about my genes? I'm more, I have a predilection for heart disease. So they are actually pushing the doctors to learn more about that. So it's patients are driving. So, okay, this is a story I want to tell about Cincinnati Children's Hospital. This is one of the third leading pediatric hospitals in Ohio. What they did is, they are a premier institution. They get, the third largest funding that they get from NIH. And believe it or not, that is where the polio vaccine is first developed by Dr. Sabin. So Cystic Fibrosis Foundation came up with the data because they have been collecting data on cystic fibrosis, and they published the data in 2000, right? They published this data, and then this is just an example of two factors that they measured out of multiple factors they measured. One of them was the BMI, and the other one was the forced expiratory volume of the lungs. And if you look at that, here, Cincinnati Children's is pretty short. This is the green bar shows Cincinnati Children's, and then the red bar actually shows average, national benchmarks, and the blue one shows about top-performing hospitals. So they were shocked to see this because they are one of the premier pediatric institutions. They were doing fantastic work. And this completely shocked them because, again, this is because of data they were able to compare. And the Cystic Fibrosis Foundation did a fabulous job of actually collecting and analyzing this data. And this was the quote that came from them saying that, okay, we have been thinking that we are the premier institutions, we have good intentions, and we are doing really hard work. And we saw the data, it is a shocker, right? So what did they do? I'm going to talk about what they did, but I'm going to show you how the graph looked like 10 years from now, right? 10 years from then, on 2010, again, the Cystic Fibrosis Foundation's data showed that Cincinnati Children's surpassed the national average, right, on both these measures, and they were getting close to the top 10 performing hospitals. So that is a phenomenal difference in 10 years. And then what exactly they did? So their story is that they focused on the outcomes. So they looked at all the factors that the Cystic Fibrosis Foundation is measuring, and they said, what are all the process procedures that impact those outcomes? And then they came up with a plan, algorithms and processes so that, okay, we are going to do this, this, and this to achieve that outcome. They educated the physicians on that. And so again, standardized care process. They educated the patients. And then they have the electronic medical record. They have the clinical decision support to support that. And they made sure that all this care process have been implemented in the clinical decision support. And then, of course, most important thing is they engage the patient. So this is an important thing because they said that, okay, patient needs to be part of the infection control police because infection is a major problem in cystic fibrosis. So they said that, okay, you guys need to watch the physician. Are they washing their hands before entering the room? Are they changing the gloves? Okay? If they don't, call out to the doctors. And transparency among colleagues. They have to call out among each other if they are not following the procedures. And then they kind of transformed the whole culture and the delivery of the care. That is what made a difference in the results that you saw. This is a fabulous story. So they did it on one particular disease and one particular hospital, right? So how can we scale that to multiple diseases and hundreds of thousands of hospitals, right? How can we take the Cincinnati Children's example and translate that scale into multiple, high expense disease process? So this is the vision, right? So we are on that path. The right information at the right time to the right format in the right channel, the right workflow time. That's very critical, right? We have to educate the physicians at what to do for this particular patient that is in front of him or her, and how to provide that information in a concise manner that is understandable, that doesn't take a lot of time, and make it easy for him to make that action instead of going to multiple places and making changes. And of course, at the right cost, meaning right cost in terms of his time, right cost in terms of outcomes to the patient. So that's extremely important that we need to have that complete works. Okay, so doctor was in the center of care before, and all these bubbles were in silos. They don't talk to each other, don't even talk to the doctor who is actually in the center. He doesn't receive any of this information from the silos. Now we are moving this into patient-centered care. So move the physicians to one of those bubbles, push the patient to the middle, and not only that each of those bubbles communicate to the patient, which is extremely important, but also communicate each one of them so that the information is consistent, information is the same, we are all singing from the same songbook, right? So that will make an impact. So, any thoughts, feedback, comments, questions?
Something.
Yes.
I was just thinking about an article that I read a couple of years ago regarding a proposal of shifting the triple aim to quadruple aim, which is the fourth aim would be to improve the work life of health professionals, avoiding burnouts and so on. So it was interesting, this article that you provide us regarding the things that clinical decision support systems can help. One is reducing, giving more time, reducing the workload of insert information in HARs and all of the systems to have more time for the patient. So I think that this is one important thing, giving more time for health professionals to take care of the patients and
Correct.
Improving their work life.
Absolutely. Well-made point. And we have been talking about it yesterday, that's really important, right? So one of the things that we saw that when we introduced the order sets in my previous life as a CMIO, we had all those choices and the order sets were too long, like 5 pages, right? So it was taking a long time for them to go through them and pick the ones that they want. And because of the data, we were able to analyze what they were practicing, and we were able to cut down the order sets to 1 page because 95% of the time that's what they chose. So that really helped to save them time, number one. Number two is that physicians are not typists, because we never learned keyboarding. And then one of the things that, some of the hospitals have scribes who will be able to round with the physicians and to be able to enter so that it kind of saves them time. And also there is voice recognition is getting better and better these days. Instead of typing the notes, right? If you can use voice recognition, that's what the physicians are used to, like dictating, right? And they see the patients, they are able to dictate. So there are multiple things that can be done to make the physician's life easier and more efficient. And we definitely need to think about that. One of the things that I was sharing this, I usually tell this story to my physicians, is that healthcare is in a point where, think about the world before the cars, the automotive, right? People are going from one place to another in horses, right? So if you ask the people what they want, they'll say that I need a faster horse. But Henry Ford said that, right? If you ask them, that's what they will say because most of the time they don't know what they want, right? And one guy came with a mechanical horse. They said that, okay, the next thing is the mechanical horse, right? So I think in healthcare, we were in a paper world, and now we are kind of digitize the paper process, which doesn't work. So we need to think about it in a different paradigm like a car. Hopefully that is in the horizon because when we are in the paper world, we have to document everything. What medicine I gave, what labs I ordered, and all that stuff. But 80% of the time is already there under my name, what I ordered, what labs I ordered. So only thing that they need to document is how am I going to plan the management of this patient. But most of the time, the requirement is that they need to document everything to get paid. So the health regulations need to catch up, and we need to think about how we should think about a digital world in the future that is more like a car than like a mechanical horse. So your point is well taken. I think we need to do a lot of homework, and we need to do a lot of work on physician efficiency. That's a whole new topic about, we talk about patient engagement. Physician efficiency is one of the important things because otherwise they are burnt out. So, well taken.
I'd like to comment something that for me it's the most interesting. It's the pull to push delivery model. Information for me it's one of the most valuable thing in everything.
Yeah.
In healthcare,
yeah.
But I think CDS, as you said, EHR plus CDS gets small quality gains. To get more value for CDS, I think we really need to change to push delivery models. And for this, it's really important to integrate AI, artificial intelligence, and data mining in CDS.
Yes.
If we get this thing together, I think we really will step to another era in CDS.
Absolutely.
Because when you think about user experience and the right information for the right physician at the right time for the right patient to take the right decision, we really need all these things together.
Yes.
Because nowadays, of course, CDS it's really important, but when we think about interoperability, it's a big challenge yet. So if you get all these things together and to show for the physician or for healthcare professionals that you get the right information to the right decision at the right time and for all the demands or necessities that the patients have, I think it's the most valuable thing that CDS can do for the patient to empower them and for empower the physicians and the healthcare workers. So I think this is the next step in CDS. I think this is I think it's not the future because we can see these things happen now, but we have to translate this for the physicians that effectively we get this thing done and brings value for what they done for the patients.
Oh, absolutely, absolutely. So that's a very good point because if you look at the airline industry, banking industry, right?
Yes.
Very easy, but of course, very simple. In banking, it's a debit, credit, and whatever. It's free. No comparison with the healthcare, right? So, but imagine the world before electronic in the banking industry, the travel industry. Healthcare needs to get there. Mm-hmm. So we need to understand physician behavior, just like you said, machine learning, right? I should understand how you practice medicine, the machine learning should, and then provide you what you want even before you ask for it. The foundation for that is digital medicine. We need to have all the data in electronic format. We need to build that because machine learning needs a lot of data, right? So it's happening in the US because most of the hospitals don't want to share their data with their competitors. So they keep their data, so it's not enough variability or enough data to be able to draw conclusions. So you need to pool the data, de-identified data, so that we'll be able to kind of draw intelligence out of the data and then translate that into clinical decision support that is more meaningful. Absolutely. Some of the things that we are working, how can we use machine learning to be able to do some of those things? Even like alert fatigue we talked about, right? So why are they overriding this particular alert? What is the patient's context in overriding? Does that make clinical sense? If we make clinical sense, next time we shouldn't throw that alert to that physician for that particular patient profile, right? Yeah. So these are all some of the things that we should definitely move forward because to get to the next level. Completely agree.
Okay.
Yeah.
Thank you. Thank you, Raj.
Okay.
Please, over the course of the day, if you have additional questions for Raj, take the opportunity at lunch and the next break in the afternoon to follow up with him on those.